My name is Yolanda Skinner, and I am a member of Grace Baptist Church, and I am the co-chair of the healthcare team. There is a 19-year difference in life expectancy for someone residing on Colorado Avenue in Bridgeport, 70 years, and someone residing on Highwood Road in Westport, 89 years. This is the story of healthcare in Connecticut. And we don't even have the data to explain this discrepancy. People are literally dying from not being counted. This is a matter of life and death.
My name's Dr. Marjie Golden. I'm a member of Temple Israel, and I'm the chief of infectious diseases at the St. Raphael campus of Yale New Haven Hospital. I've spent much of my career in an infectious disease clinic in New Haven, working tirelessly to provide the highest quality medical care to my patients. I'm going to briefly share the story of one of my patients who my team felt would have received different care had he not been a person of color. A 52-year-old man, somebody's husband, a father of 3, was working as a medical van driver when he got sick a week after driving a patient to a medical appointment. Despite having many of the risk factors that we know predispose to severe COVID infection, when he called his doctor complaining of fever, headache, and cough, he was given antibiotics over the phone and not told to seek COVID testing. His symptoms got worse, and over the next few days, he made 2 separate visits to the emergency department. A chest x-ray was done only after he insisted on it. And even though he had evidence of pneumonia on x-ray, no COVID testing was done, and he was sent home. He ultimately became so short of breath that he called 911. By the time he arrived at the emergency department, for the 3rd time in 4 days, his oxygen level was dangerously low. Within 3 hours, he was on a ventilator. By this point, his family was understandably so disgusted and frustrated with the medical system that when they were approached about enrolling him in a potentially life-saving clinical trial, they declined. I wish this story were an aberration, but sadly, it is not. As a physician, it is infuriating and disheartening to see patients receive substandard care. We must have race, ethnicity, and language data in order to identify trends so that we can ensure all patients receive high-quality care.
My name is Lorraine Ramsey, and throughout my life I have experienced many troubling encounters in the healthcare system. I broke my tailbone after suffering a fall at work. I went to the emergency room at Norwalk Hospital, where I met with a young physician, and after a verbal examination, no physical contact, I never disrobed, she never looked directly at me. She prescribed me oxycodone, and she immediately hurried away. I remember feeling like, what just happened? The next day, I took the prescription to be filled at my pharmacy in New York City. They refused to fill it. They were shocked that I had a prescription for oxycodone. They advised me to take the prescription back to Connecticut. I did as advised, and I went to Walmart and filled the prescription. No questions were asked. The physicians knew the dangers of this drug, and yet they never explained to me that I should take it only if it's in excruciating pain. They never asked me my level of pain, and I was not in excruciating pain at the time. I truly believe that had I been a white woman, that the physicians would have looked at me, given me eye contact, advised me appropriately, and given me better health care. Instead, they haphazardly prescribed me a very addictive drug and set me on my way.
My name is Dr. Jessica Isom, and I'm a clinical psychiatrist and instructor at the Yale School of Medicine. When solving any dilemma, defining the problem is essential to finding the proper solutions. And in order to solve the problem of racial disparities in healthcare, which exists by design, we first need to define the problem accurately. Good data collection is the best tool we have to do this. In my own clinic, which serves majority Black patients, I noticed that I had been prescribing stimulants to mostly white patients. These white patients were overrepresented despite ADHD being prevalent among all racial groups. I also noticed that only English speakers were receiving the stimulant medication, despite a diversity of languages spoken by patients in the clinic. ADHD can affect employment, interpersonal relationships, day-to-day life, including being successful as a parent. Using data, I changed my approach to diagnostic evaluations and was able to address the issue. I began standardizing my initial visits to ensure that all patients across the board were screened for ADHD. I paid careful attention when a language barrier was present to ensure non-English speaking patients received equitable care. Without disaggregated data separated by race, ethnicity, and language, we miss opportunities to provide patients with the best care. Imagine how many lives would improve in mental health and beyond if we had the information that we needed. We need better data to understand the problem and generate actual solutions. And as an equity-focused physician, this data is essential to my success. Thank you.
Because Connecticut does not collect standardized data on race, ethnicity, and language of patients, we cannot understand the immensity of the problem, nor can we identify solutions to the healthcare disparities we face. This is not okay. We are not okay. In order to address racial health disparities, we first need data. Without it, we're flying blind. The need is urgent. The time is now. We need to pass REL legislation in 2021.